All right, good. Good afternoon, everyone. Hopefully you can hear me. This is Katie Cook from Adirondack Health Institute. Welcome to the September Telehealth Learning Collaborative. We have a busy agenda today, so I'd love to get started. I sent out the agenda about 2 weeks ago, and our speaker today, I'll get to him in a second, but we have on the agenda, as always, updates from our 4 state agencies. I believe most of those folks are on the line today, so if any of you on the line have a particular question for either the Department of Health, the Office of Mental Health, the Office of Alcoholism and Substance Abuse Services, or the Office for People with Developmental Disabilities, please send that through the Q&A box. We will triage those and ask those questions to those folks as their time on the agenda comes up. So again, please submit any questions you have regarding telehealth for those agencies ahead of time. Most of them don't have large updates today, but if anything comes through, we will, of course, get that going. So while I give the speaker introduction, Dan Halpern is on the line. Dan, you will need to share your screen. There is a share button at the top left corner, which will allow you to do so. So Dan is with Physician One Urgent Care. He's going to be discussing redesigning healthcare quality management for the e-health age. Some of the takeaways from today include understanding principles, successes, and challenges of healthcare quality management. Digital health, together with the educational and empowerment competency of telehealth, will lead to the evolution of the empowered patient. He will discuss remote patient monitoring and the opportunities of multi-channel monitoring, and then overall quality management as it relates to telehealth encounters. So Dan, are you able to share your screen?
Yeah, I have my screen. I don't know where to share it. Oh, share?
Yep. If you click on the share
screen.
and then hit my screen, it should come right up.
How's that?
Excellent. So you are good to go if you want to pull your PowerPoint up.
Okay. Is that visible to everybody now?
Yes.
Okay, how's that?
There might be just a slight delay, so I don't see anything yet.
So, does that show up?
Yep, I just see the top part, so you must have it.
That's all I wanted to show right now.
Perfect, you're good to go.
Okay, so I'm sorry for any of the confusion. Somehow my phone just stopped working, and that produced a major problem. At any rate, I'm Dan Halpern. I'm a physician, and I have about 35 years of emergency department experience and about 10 years of experience in urgent care. And a couple years ago, I decided that I wanted to do something that wasn't reactive. Both emergency medicine and urgent care are reactive, and I decided I wanted to do something a little proactive for the rest of my career. So I went and did a fellowship in e-health at Jefferson in Philadelphia, and there decided that one of my great loves, which is quality management, should be brought to telehealth because it's not there currently. So my sort of epiphany was that telehealth does need a rethink of the way quality management happens, and so the answer to that question is yes. And the answer is because our goal must be the optimization of the value proposition, which is value that equals quality, a measure of quality, a measure of access, and a measure of cost. So obviously, as quality and access improve and cost decreases, we get better value. So eHealth does a great job on access, which it increases, and cost, which it reduces, but has not prioritized the opportunity to provide what has never been provided, which is real-time quality management. And I think that we all know that real time would be very useful. So within quality management, there are two basic activities. One I call the CEO level, which is provision of care, and the other is the chief operating officer level, which is risk management and other things, as you can see. On the CEO side, we've evolved from very early quality assurance through quality improvement, continuous quality improvement, and now the buzzword is total quality management. And total quality management, for the very first time, adds a dimension of organizational improvement. That is, what is the organization doing, not just individuals within it, and a focus on customer desires. It's amazing that it took us that long to get from quality assurance, which is a somewhat punitive activity, to total quality management, which finally takes a look at the patient. So the quality management for eHealth, the challenge is to use tech to advance the value proposition. And that is beyond all sorts of all this video conferencing visits and monitoring streams and online learning and digital health is the fundamental challenge to use technology to substantially change the value proposition in healthcare. Now, I understand that I just came back from a telehealth research symposium in Chicago, and it's clear that we still have a lot of just very basic operational challenges. That is, to get some of these programs started, reimbursement is an issue, provider and patient acceptance is an issue. So there are all those issues out there. And sometimes it's nice to take a look at the horizon beyond that. And so that's what I'm trying to do. My feeling is that at the very end, we have to provide healthcare that is efficient, safe, rooted in the patient's desires, outcomes, and satisfies the providers of care. That is the quadruple aim, which is that was basically articulated about 10 years ago by the Institute of Medicine. And it is patient experience, population health, reducing costs, and team care team well-being, which is the fourth, which was not part of the original three, but with all of this problems that we have with staffing and whatnot, we've got to, and burnout and whatnot, we've got to look at that fourth element. So I'm going to very quickly go through what I'm planning to do for the next just 10 minutes or so. And that is that despite a significant investment in quality management over the past 50 years, we still have a bunch of nagging healthcare problems, and I'm just going to very quickly go through them. Quality management is good at measuring processes, that is, very finite bits of information, not so much at measuring outcomes. The question is, how is quality management done in the non-e-health world? And I'll talk about that for a minute or two. And what does e-health quality management look like? And what do we need to get there? My point is that this is something that we need to start thinking about. We can't just think about it after all the technology is there. We've got to be prospective. That is, we just can't saunter up to it. And finally, a bit of a summary. So comparable countries have an average life expectancy of 82.2 years. In the United States, it's 78.6 years, and that gap is growing. Disease burden rates are 31% higher in the United States compared to comparable countries. Admission rates are higher for things that we could have avoided. Healthcare spending per person was in 2017, $10,700. It's now about $11,400. On the average, other wealthy countries spend about half as much for that per person. That amounts to about $1 trillion a year that we have going into healthcare, and that's just not buying us much more quality. But some measures we're 19th in the world. U.S. health consumption accounts for 17% of the GDP, whereas it's 10.6% in other countries, and I think everybody's familiar with some of these stats. So we're good at measuring processes. I don't know if you're familiar with the Catalyst, which is an opinion and planning arm of the New England Journal of Medicine. And they polled people, usually healthcare executives and physician leaders, And they either agreed or agreed strongly that existing quality metrics tend to measure processes rather than outcomes. The Agency for Healthcare Research and Quality, which is a powerhouse for quality management, articulated 6 domains of healthcare quality. Number 3 was patient-centered, providing care that is respectful and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. So how can the industry overcome the lack of experience in effectively utilizing patient-reported outcome measures as a means to improve care? And I think I have an answer to that. So the process measures are things like blood sugar values, hemoglobin A1C values, looking at chief complaints for specific elements like lethargy and see if blood sugar is checked with an acceptable frequency. May look from time to time from the time hemoglobin A1C is found to be elevated to how long does it take to get patient education on that, or any number of other process measures. So in the non-e-health world, if you need to determine if the data and logic is there for the diagnosis and treatment, or if the case is proceeding toward a socially or patient-centered outcome, which would be needed to meet ARC number 3, you will need to do chart review. Well, we have about 1 billion provider-patient encounters annually. If we were to look at even 10% of those, we would be spending about $1 billion. And as we all know, when you do chart review, it usually is some distance to the event. So you may get your chart reviewed by some medical director or whatever, and it may be 2 or 3 months before the review of that particular encounter gets back to you. And it's usually because there was some, patient complaint or something like that. So it's usually random in most people's hands. And I will tell you that the teaching moment as a clinician and having supervised physicians, the teaching moment is what you really want. And the teaching moment is lost when the event is somewhat distant to the time that you're interacting with the provider. So real-time feedback is the teaching moment. And also patient safety. If something is being done that is unsafe in an interaction and it takes us a patient complaint or a lawyer's letter to get back to it, we've really failed. So we need to be doing all this stuff in real time. So what's happening out there is that natural language processing, and natural language processing is the Series of the world, where you say something to your Google speaker or your Amazon speaker or whatever, and it turns on, radio station XYZ for you, or turns off your stove, or adjusts your thermostat or whatever. That's all natural language processing. Augmented intelligence says, what can the computer learn from reproducible behaviors? And so what we will come to use all this for is outcomes assessment, both patient and societally centered, process measures, the good old ones that we just spoke about, real-time assessment of encounters available to the provider and patient as a capstone to the encounter. So the provider and the patient have an appointment. They talk together, and as when they say, and I guess that's it for the day, out of the computer comes a report on the efficiency, quality, and aspects of outcomes management that encounter provided. And I will say one of the great opportunities here is that keyboard that sits now between most patients and their providers. And that keyboard, under these circumstances, would go away. So what do we need to do to get there? Well, you might say, well, what does all this have to do with telehealth? Well, we have an asset in telehealth which is underappreciated and certainly not used, and that is we have a potential to voice and video record, but certainly to voice record the encounter. So the video conferenced encounter is gold in all of this, and it's what makes it able to happen. Natural language processing will produce a digital record of the encounter, which include both the patient's and the provider's input. And I would tell you, as a healthcare provider, that the patient's presence in the chart is only the presence as interpreted by the provider. So all of this allows us, for the first time, to have a clear image of what the patient is saying. The record is then scanned against a series of algorithms that have to be developed, and this is the hard part, and it's something that can happen, but it's going to require a lot of work. In real time, the visit record and an evaluation of the visit is posted to the provider, who shares it with the patient. Corrections can be made by a natural language processing, and the patient and the provider verbally sign off on the visit. I think that's tremendously exciting. And just to show you that I'm not way out, well, I'm probably somewhat out in left field with all of this, but I think that it's going to be something that will be upon us in the not too distant future. The Center for Medicare and Medicaid Services has put out an artificial intelligence health outcomes challenge, where they're willing to pay as much as $1.65 million in awards to a process which is going to involve a lot of IT people trying to figure out how they can make algorithms that predict healthcare outcomes. And that I think, if nothing else, we will get much more efficiency out of those billion visits. The person that's doing this is Lisa Barry. She's in Baltimore with CMS. So what critical healthcare advance? So this is everything I've spoken about is a healthcare advance. What critical healthcare advance takes 17 years to become integrated in everyday practice? And the answer to that is almost all. That is, people have taken a look at this, and an advance which is well described and well formulated and proven still takes as long as 17 years to get to practice. Well, we don't have 17 years. The research that needs to happen, we have to get ahead of the curve here. The research needs to happen would look at thousands of structured telehealth visits. And by structure, I mean something very simple. It's a SOAP note, which is generated for each ICD in a telehealth visit, with the recording of the visit saved to the patient's chart. And that with many of the systems that we're using these days, there's memory available for that. And different vendors could provide that for people. Of course, this has to be done with patient consent and whatnot, as any other research project. This is easily done in your practice. It will easily become material for the research that I'm speaking about. So, in summary, eHealth is in a unique position to revolutionize costly, inefficient, and inadequate health care quality management by parenting processes that will move quality management from a small sampling. Today, probably less than 0.01% of charts are actually quality reviewed. From a sampling of healthcare interactions to a universal real-time assessment of every interaction and its trajectory, and that is my dream for us. The tools that need to be here are key metrics. Now, key metrics have, once again, the Agency for Healthcare Quality and Research, AHRQ, has articulated a bunch of key metrics. What we don't have are key outcomes, and we certainly don't have them as pertain to individual patients. So joining the tech community to provide the massive number of structured encounters needed to teach the computer how to find the answers. The reason I'm presenting this is I want people to start thinking about where we go from here, and this is one of the places we can go. So I would love feedback. I know some of this is confusing and very new worldish, but I would love to have some feedback, see what people are thinking. My telephone number is there, so that's texting. And if you text to that number, a quick text would be so very much appreciated. Thank you very much.
Excellent. Thank you, Dan. So we'll wait a minute or so to see if any questions come in. I did have a quick question about the CMS innovation you spoke to. Is that currently happening, planned to happen, or already happened?
Yeah, so that competition is something that, as I said, Lisa Barry, who is really I've looked at some of her research. It's really mind-blowing research, and she's in charge of the Center for Medicare and Medicaid Innovation Center as part of CMS. So she's an innovation kind of person, and this challenge is already out there. It's not going to any healthcare providers. It's mostly going to IT people to see if they can develop the algorithms that are necessary. And as I said, it takes we as providers have to step up to the plate and find ways to develop these data banks so that we can give it to the IT people so that they can do their work. Without clinical events, this will never happen.
To your knowledge, a question did come in. Is there any software that can do some of what you've already described?
Well, so I suspect some of the folks on this are in an EMR. I strongly suspect, although it's not publicly known, that Epic is looking at this because they have access to an enormous number of interactions. The problem with that is that what Epic is looking at, usually if you do an encounter in Epic, it requires that you fill in specific fields with a sort of a drop-down menu. It really loses the patient's voice. So the difference here is using natural language processing. Natural language processing is out there. It's very good. I don't know if any of you use Dragon, but it's very good. I use it all the time in my practice, and there are very few errors, and the more I use it, the fewer errors there are. So yes, pieces of this are out there.
Okay. Another question came in. Are you aware of any other countries that have started along this path?
Well, not countries, but it would always be nice to be a leader. When I do literature searches, I find elements of this coming in from Germany and France and Sweden, a lot from Norway. So I would answer yes, but I don't think I can give you specific references on the holistic approach that I've talked about.
Okay. It doesn't look like any other questions have come in. So, of course, stay on the line. If a question pops in, I'll ask it. But thank you, Dan.
And I just want to say that I will be at the annual meeting on Lake George.
Yes.
In November.
Excellent. Yes, and I am going to talk about the conference here in a little bit. So, yes.
So I'll be there if somebody wants to talk about this.
Sounds good. Thank you.
Mm-hmm.
All right. So moving along on the agenda is a quick update from DOH. Megan, I know you're on the line, so if there was anything you wanted to add or make note of, please feel free to hop on.
Yes, hi everyone. This is Megan Procorum with the Department of Health. No major updates to speak of. We continue our interagency work to develop an interagency telehealth guidance document. This is pending some of the finalization of the updates from the other agencies that you'll hear on the call today.
Excellent. Thanks, Megan. And actually, real quick, Dan, another question came in. Apparently, Lisa has left CMS as of September 4th. Do you have any indication as to who may be running that program now?
No, I didn't know that.
Okay.
I guess somebody looked at her. So just very briefly, I will tell you that I met with a guy that does this research out in Seattle, and it's in primitive stages. But I said, how come you can't move any faster? And he says, every time I hire somebody to work on this, they get hired away by Amazon, Google, IBM. And so I'm convinced that this reduction by natural language processing and sequencing through algorithms to look at results, I'm convinced that these folks are doing it. I think they're doing it aggressively, and I wouldn't be surprised if she went to work for some of those people.
Yeah, there's a number. If you do a quick Google search, there's a lot of press releases on her leaving. So thank you to the individual who pointed that out. One more question that did just pop in. So the question states, if I am understanding correctly, the CMS initiative is looking to use algorithms to replace clinical intuition?
So that's a myth that is out there. The algorithm, could that happen at some point? Yeah, it could happen at some point, but I do think that the algorithms that I'm discussing really take a look at the events that occurred during a provider-patient interaction and take a look to see whether those events are progressing towards a patient-stated outcome. So it's pretty narrow. We're not going beyond that. Although the danger is always that things will go beyond that. But I think that some of the intuition issues and having, done clinical medicine for over 40 years, it's going to be very hard to replace a lot of that. But this particular presentation does not deal with replacing clinical intuition and diagnosis. It's really an aid to say, well, you guys have just spent 15 minutes with each other, and you really haven't touched the outcomes or elements of that outcome that you need to work on to make it happen. And so that's a fairly narrowly defined goal.
Okay. All right, thank you. There are no other questions at this time. All right, moving along on the agenda is an update from OMH. Amy, if you could unmute your line. Several questions from folks around the state came in advance of today's session that I just wanted to pose to you amongst the group. So you should be able to unmute your line. Okay, maybe not.
Nope, there you go. All right, I didn't realize I had to do it on the computer as well. Sorry about that.
No
I hadn't
worries.
muted on there. Okay, yep, I'm ready. So if you want to let me know what you have.
Sure. So in a meeting that I was in last week, and I already know the answer to this, but it would be good for the group to hear it. The question of Part 730 orders came up and whether or not this would currently be allowed or ever be allowed through telemental health through OMH. And I know this was addressed in the July 3rd register, but I'd love to just hear it from you.
Yeah, whether we're considering for any type of involuntary admission, no, telemental health cannot be used for that at this point.
Okay.
Yeah.
And sorry, go ahead. Was there more to that?
Nope, that's it. I mean, we've had a pilot going on for a while with a couple of our hospital systems, and we had actually hoped to get that added in with this most recent, but it didn't make it in. So it still stands that it's excluded within our current regulations.
Okay. And then the last question that came up a few weeks ago was, would OMH ever consider the telephone as a means for telemental health services of any kind?
So just a phone call between the recipient and the provider?
Right, and I think that may have come up because CMS, as of January 1st, created those two sort of virtual check-in codes where the phone can be used. So I think the question came up is, would OMH consider that as a billable service?
I don't think that I know we wouldn't currently. I don't know that that's something that we're looking at, but it doesn't mean that we couldn't talk about it down the road. But no, we wouldn't consider that to fall under a telemental health billable service.
Okay, thank you, Amy. That was it, unless you have any other updates for the group.
I don't. Nope. We have just to let everybody know, the updated guidance is circulating for executive review, and once they give their final sign-off, it'll get posted to the website. So I can let you know, Katie, so that you can share that with the larger group.
Sounds great. Thank you, Amy.
You're welcome.
And as for the other two agencies on the agenda, no questions have come in for OASAS or OPWDD. So we will go ahead and skip ahead to updates from the North Country Telehealth Partnership. I'll first open it up to Bob at Fort Drum if he has any updates at this time.
No updates at this time. Still working on a digital retinopathy program, and we will have an update for that on the next call. But really, that's the major thing that we're working on. I think we're just kind of laying low until you finish your conference later in November.
Excellent, thank you. So that is a nice segue into conference updates. So as many of you on the line are aware, the partnership puts on an annual conference. This is our 5th annual. It's happening on November 6th and November 7th at the Fort William Henry Hotel and Conference Center in Lake George. The pre-conference is currently sold out. If you are interested in attending that, there is a wait list. However, there are still roughly, I'm going to say 30 open spots for the full conference day of November 7th. So we expect that this event will sell out. Sponsorship opportunities are closed at this time. So thank you to anyone on the line who has supported us. So again, if you are interested in coming to this conference, I strongly encourage you to register as soon as possible so that you do not end up missing out. Obviously, the highlight of the day includes our keynote speaker, who is Dr. Jonathan Neufeld. We have healthcare attorneys coming in to speak about Medicare and federal regulations. And of course, many of the folks that are staples to the Telehealth Learning Collaborative agenda, such as Megan, Amy, Carmelita, and I believe Dr. Virginia Scott Adams from OPWDD will be on a panel that afternoon talking about telehealth regulation, and that always seems to be the highlight of the event. Additionally, a couple of other opportunities include some upcoming educational webinars that we will be putting on. These will be in December and February. The one in December is going to be focused around reimbursement, and the one in February, we actually have a payer who's going to present on telehealth from the perspective of the insurance company. So more information will come out on those as we get closer to those dates. And then lastly, I wanted to share an update on another Project ECHO that's happening in New York State. It's called the ECHO MOLST, and that is around honoring patient preferences at end of life. New York State is working towards an electronic system for end-of-life care and advanced directives, things of that nature. So this is being put on through Excelis. It will be on Wednesdays from 12 to 1 using Zoom. There are continuing education credits for physicians, nurse practitioners, physician assistants, and all others who participate in the MOLST process. There's a total of 8 sessions, and that is going to be starting in the next couple of weeks. I will send out a flyer with more information on that for any clinicians or practices who may want to join. And before we wrap up, Megan, a question did come in for you. It might be for Megan or Amy. I'm not sure. It's not specified. But it was just a note that it's not written in public health law that the use of just a phone call as telehealth would be permitted. The definition under public health law says audio telephone alone is not included as telehealth. So that's just, I think, a point of clarification more than it is a question. Megan, if you want to just confirm.
Yes, absolutely. This is Megan, and that is correct information for public health law that authorizes our Medicaid fee-for-service policy. By definition, statutory definition, telephone-only interactions are currently excluded from Medicaid fee-for-service reimbursement.
Excellent, thank you. And one question did just pop in, actually, Megan from OPWDD, if you could unmute your line. A question came in asking if there is an active internet site that can be reviewed. I'm assuming that means some sort of regulation or guidance. Maybe you could give us a brief update on that. I'll give you a minute to unmute your line. And I think while she's doing that, she did comment to me earlier that in terms of OPWDD, the ADM is still being reviewed. So I would say that my safe answer is there isn't an internet site available for any regulations to be reviewed at this time. So with no other questions, I am going to, okay, yes, yeah, there is not an active site or guidance to be reviewed, but as soon as we are aware of guidance for any agency, we share it with the larger group. So don't worry, you won't miss out on anything. The next Telehealth Learning Collaborative is going to be in November after the Telehealth Conference. It will be on Monday, November 18th at the same time, 2 to 3 p.m. Speaker to be announced. We do have one lined up, but we will share that information as we get closer. Again, the slide deck and the recording and any notes will be shared later this week with all of you. Thank you for attending, and I hope you have a wonderful day. Thanks.